Hi, everyone. My name is Lynn Hernandez, and I'm with the Desmoid Tumor Research Foundation. It's wonderful to be here with you today. We welcome you to this DTRF webinar entitled Cryoablation, What We Do and Don't Know. Today, we'll learn how cryoablation is performed and how it works. We'll also talk about what we do and don't know about this treatment option for desmoid tumors. We're honored to have Doctors Jean-Emmanuel Kurtz, who will be talking about cryoablation specifically, and Dr. Bernd Kasper, who will discuss other treatment options, including the most recent revision to the global consensus paper. Jean-Emmanuel Kurtz is a medical oncologist at the University Hospital of Strasbourg in France. His main areas of interest are gynecological oncology and mesenchymal tumors, with 150 peer-reviewed publications. He's been involved in the multidisciplinary Mesenchymal Tumor Committee for over 20 years. Dr. Kurtz is a member of the French Sarcoma Group and works closely with the Interventional Radiology Department, headed by Professor Afshin Ganji. Together, they have conducted clinical research studies on cryoablation of desmoid tumors and organized joint consultations for patients with desmoids. He's also deeply involved in the French patient advocacy group SOS Desmoid, of which he's general secretary. Together with Professor Gabriel Malouf, Dr. Kurtz leads translational research projects on mesenchymal tumors, including desmoids. I'd also like to introduce Professor Bernd Kasper, who works with the sarcoma unit at the Mannheim Cancer Center at the University of Heidelberg. Professor Kasper's profession is dedicated to patient care and research in soft tissue sarcoma, desmoid type fibromatosis, desmoid tumors, and gastrointestinal stromal tumors. He's head of the study center of the German Interdisciplinary Sarcoma Group, and he serves as the past chair of the EORTC Soft Tissue and Bone Sarcoma Group, and outreach chair of the Connective Tissue Oncology Society. Professor Kasper has authored more than 100 scientific publications. He's a dedicated board member to patient organizations dealing with desmoid tumors, such as the Sarcoma Patient Advocacy Global Network and the DTRF. So welcome to you both, Dr. Kurtz and Dr. Kasper. We know it's about 6 p.m. in Germany and France right now, so we thank you so much for joining us this evening. Just some quick instructions before we get started. During this webinar, we invite the community to post any questions for these two presenters in the Q&A specifically. In the interest of time, our presenters will hold off. They might be answering questions during the event, but may also be holding off on answering questions until the end of the talks. Community members are welcome to connect with each other in the chat, which will be unmonitored. We will not be taking questions from the chat. So if you have specific questions, make sure you post them in the Q&A. Okay. Dr. Kurtz, I would like to turn it over to you. Thank you.
So thank you so much. This is really impressive. Lynn, can you confirm that you're seeing my slides actually? All right, so welcome everyone. It's really a pleasure and an honor to talk today about cryoablation. As it was mentioned, I'm a medical oncologist, but I work in close relation with the interventional radiology team, so I feel quite a bit comfortable in speaking about cryoablation. So just a few words for desmoids. So you know that it's a rare disease. It arises from musculopeneurotic structures. It's ubiquitous. It has an unpredictable behavior, and it's marked by pain, disability, rarely death, obviously. It can be even sporadic when you have beta-catenin mutations. This is the Venus de Milo here who helps us in understanding that. So sporadic mutations happen in the tumors and they cannot be transmitted to the children. On the other side, the mutation can be germinal. So it is indeed in the germinal cells, and it can be transmitted to the next generations. This is really uncommon, and it happens in FAB syndromes or Gardner syndromes. This is of importance since the localization of the desmoids can change slightly between those two settings. So we will discriminate between intraperitoneal and extraperitoneal desmoids, and those intraperitoneal or mesenteric desmoid tumors are a little bit more frequent in FAB patients. They have a distinct prognosis, and due to their localization, they are less likely to be accessible to interventional radiology techniques for obvious reasons, because you have to go through, the bowel or important structures in the abdomen, and this make these tumors less accessible indeed. So what do we know currently about cryoablation? The technique is mature. It has entered the guidelines that were updated by the fall of 2023. We know that the technique can be achieved in expert interventional radiology centers. The side effects are manageable, and it does benefit some patients with recurrent disease. So what is actually cryoablation? That's an interventional radiology technique. It's called thermal ablation. And you might know that thermal ablation can be done with either heating or freezing the tumor. It's different, but the principle is the same. And in cryoablation, of course, we are using the code. And this technique stands besides radio frequency or microwaves that are less adapted to desmoid tumors. It's not that new because it was initially reported in desmoids by the MSK-CC team in 2010. The basics of cryoablation comes from a physical effect that is called Thomson-Joule. And when you deflate some gas, the temperature is modified and it's freezing. And the idea is to have argon gas circulating into needles, and the gas is compressed, and when it's decompressed at the extremity of the needle, it's really cold, and it goes to between -20 / and -40 / I'm sorry, I did not translate into Fahrenheit degrees, but trust me, this is really cold. And what happens in the cells is that the water that is in the inside of the cells crystallizes, and it's becoming ice. And you know that water in the form of ice take more space than liquid water, so it pops the cells just like popcorn. When you're making popcorn, the volume increases inside the cell, so the cell die, and there is no resistance ever possible because it's really a physical effect. And you see here that this is a kidney, and many probes coming here, and you see that in this setting there are several ice balls that are coming together, so the entire tumor is destroyed. I have a problem with my slides. Okay.
Let me know if you need help.
Yeah, I cannot go to the next slide. Something is happening here. So
I can, hold on, let me pull that up for you.
I'm so sorry.
There's actually, if you want to move to,
Let me move to the next slide. And all right, so do you see that? I suppose so.
yes.
All right, so this is the translation of my last slide live. So this is the operating room. It's here an MRI room with Professor Ganji working right here, and we put the needles in the tumor at equal distances. So when the ice ball happens, they are coming together to freeze the entire tumor. So this is the tumor, it's a shoulder just before the procedure. Then you see all the needles in the tumor. Then this is the external view before the gas circulates into the needles. And when the gas circulates into the needles, you see that it's really, really cold. And we can see the development of the ice ball live during the procedure. So it's very easy to control the size of the ice ball and the size of the volume that has to be destroyed. And this is an aspect of the same tumor weeks after the procedure. And you can see that it's not taking the IV contrast. And here it's quite a bit liquid. It's like jelly, and the tumor has almost disappeared. And this is not tumoral. This is only the resorption of the jelly that is inside the tumor that is here completely destroyed. So this technique was started in a few patients, and a few years ago we decided to undertake a prospective study to really evaluate the efficacy of cryoablation in desmoids. So this was the CryoDesmo-01 study, and it was the first prospective study of cryoablation in desmoids. We enrolled adult patients with extra abdominal desmoid that had progressed after at least 2 lines of medical treatment. The primary endpoint, the goal, was the non-progression rate at 1 year, and we had a lot of secondary endpoints such as quality of life, pain, and of course safety. So I can go through the inclusion criteria and go to the results. So 50 patients were enrolled on the study. They had quite big tumors, you see, really big tumors, because those tumors were progressing after a few previous treatment lines. And what we observed is that the technique was really useful, as more than 85% of patients were considered as responders using either the RECIST criteria, which are the standard criteria for assessing response on CT or MRI, or a different measure, which is the uptake of contrast products. So more than 80% of patients were considered responders. And when it comes to side effects, they were really mild and moderate. Some pain just after the procedure due to the swelling of the area, some paresthesia or dysesthesia in case of vicinity of a nerve, edema, skin burn when the tumor is quite close to the skin because it's really cold, like in the winter, and a few patients with rhabdomyolysis, which is some destruction of muscle in the eyes. But all these side effects were transient and really manageable, and all patients recovered from the side effects. Interestingly, we measured quality of life, and you can see here that the quality of life of patients really increased quickly after the procedure. At least from month number 2, it was considered normal and didn't decrease afterwards. And we also observed that the patient had less anxiety, less depression, because they had less pain, a better quality of life, and they also had an increase in their daily activity. This was highly significant. And when you look at pain, you see that there is a very transient increase of pain in the very next days after the procedure, and this is why we keep the patients in the hospital for a few days to adapt the painkiller treatment. And then the pain decreases significantly, and it's really nice from months 1 and 2. And both the severity of pain decreases and the interference, which is the consequences of pain on daily living. And this is the painkiller intake, and you see that it decreases, and most patients do not take any painkillers in the next months. And it works even in large tumors. This is an example of a patient who had a large tumor of the shoulder with 2 years after, a very, very good persistent response, so good results. And we can even treat patients who have large tumors requiring chemotherapy, for example. This is an example of a woman who had a chest wall tumor that had progressed after many different treatment lines, and she underwent some chemotherapy to pegylated liposomal doxorubicin. This is Doxil in the US, with some degree of response. And then she had the cryoablation. You can see here all the needles, as I mentioned before. And the result was excellent with, again, this aspect of jelly into the treated zone that progressively vanished and was resorbed, coming to an almost complete response. And she now works nicely, comes to consultation by bike, 25 kilometers, 18 miles, I suppose. So we know that it works, but at this point, it does not work always in all patients. You can see that the median progression-free survival was not reached in CryoDesmo 01. And we found that the only variable that was linked to the risk of progression was the tumor size. And we did not find ever any progression in the cryoablated zone where there is this kind of jelly, because all the cells are dead. That's fine. And we know also that when people progressed after cryoablation, it's generally at the extremities of the tumor in zones that were not accessible to cryoablation. This is an example of a woman who came from London, UK, to our center, and she had this huge desmoid tumor of the hip, and she was treated, you see, January 2018, and in June 2019, this was fine here, all still this aspect, but you could see tiny uptake of products of contrast right here that increased at the extremities of the tumor. So this is where we have some failure. We can treat small tumors with complex locations. Here on the foot, sorry, you can see this small tumor, very inflammatory, painful, with involving almost the front line of the foot. And after cryoablation, the foot went back almost to normality, and this woman was able to walk absolutely normally with no pain. This was really exceptional. So we know that cryoablation works as a salvage treatment in patients who had progressed to at least 2 lines of treatment. And what we don't know and what we want to know is whether cryoablation could replace the first medical treatment in patients progressing after watchful waiting. So this is why we designed together with Afshin Ganji the CryoDesmo 02 trial, which is now open and recruiting in France. And in this trial, we will compare frontline cryoablation to medical treatment, which is, generally speaking, oral vinorelbine. And if patients do progress after cryoablation, they will switch to medical treatment as second line, and vice versa. Patients progressing on medical treatment will switch to cryoablation. And this is a randomized trial. So we will have definitive, rock-solid evidence if cryoablation is superior to medical treatment frontline. So it's important to do that because we think that if we go earlier in the history of disease with cryoablation, we will be able to treat the tumor entirely, to have good margins. And the secret goal, my secret goal of the study, is no recurrence at all and cure of the disease. So this is, well, I hope it will happen. I think we can make it, and probably, yes, we can. So still we have things that we don't know. Of course, not all desmoid tumors can be treated with cryoablation. I mentioned the mesenteric tumors inside the abdomen because of the proximity of organ at risk. And if you freeze the bowel, it's going to make a hole in it, so it's not possible. we don't know whether cryoablation is able to replace first-line therapy, nowadays chemotherapy, but this is the goal of Cryodesmo 02. We don't know whether it's possible to re-challenge a patient with cryoablation. We know it's feasible in some instances, but there is no solid data that supports this. And we actually don't know where is cryoablation going in the future. So what happens now? Diagnosis, wait and see, chemotherapy, PASO, for example, then cryo, and Bernd will tell us, maybe neurogagestat later. Oh, neurogagestat and then cryo, and this is only salvage because patients will have progressed after those lines. But in case Cryodesmo 2 is positive, maybe we will have diagnosis, wait and see, and then cryo, and then all the sequence you can imagine, and maybe, again, for some patients, cryoablation later to handle small recurrences that can be completely treated with another cryoablation. So to conclude, yes, cryoablation has a future in desmoid tumors. We know that randomized trials are feasible in desmoids. It's recruiting. We need more patients, of course. Some tumors are still not accessible, but the Cryodesmo 2 is open. And remember our circuit goal and help us in recruiting the patients, at least in Europe. A few words to finish. The challenge is to identify the right patients who might benefit from cryoablation. One size does not fit all. Most patients are interested with cryo and want to have cryo. But remember, no tumor growth, no symptoms, no cryoablation. It's not cosmetic, it's not comfort, it's so far only for tumors which are progressing. And my last slide, I'm not in this slide because I'm a medical oncologist, and this is the interventional radiology team, and this is right here, Professor Afshin Ganji. All right, back to you, Bernd.
Wonderful. Okay, so Dr. Casper, let me get your slides up and we'll get you started.
Perfect. Thank you very much, Lynn, and thank you very much, João-Emanuel, for the for the perfect highlights of cryo. What I would like to do now is bring all this a bit into perspective and share with you the update of our consensus initiative from last year, from this working group, which we called the Desmoid Tumor Working Group. And I will, of course, focus a bit, as I'm also a medical oncologist, I will focus a bit on the systemic therapies and show you the latest results here. I just want to highlight at the beginning that this initiative of the consensus is from the very early beginning an initiative, a joint initiative between us as medical experts and you, the patients and patient advocates, from more or less all over the world now. Lynn, if you go to the next slide, this initiative now actually dates back 10 years. We started that in 2014 and had the first meeting in Frankfurt, Germany, in my home country. And that was actually a rather small group. We started that in Europe with experts from the ERTC, soft tissue and bone sarcoma group, and patient advocates from SPAN, which is by that time it was the European Patient Organization, also covering desmoid patients. And the idea of this first meeting was more or less to harmonize the treatment recommendations and management strategies for this disease. And we came up with the first paper, with the first position paper, which was published to 2015 in the European Journal of Cancer. The next slide, we then actually pushed the whole initiative forward within two aspects in 2018. First of all, an evidence-based literature search and evidence evaluation was done by an external institute, which is also based in Germany. And secondly, and this is maybe the most important point, we pushed the whole initiative on a global scale. So the desmoid tumor working group went global. We invited our colleagues and also patient groups from more or less all over the world, from North and South America, from Canada, from Asia, from India, and so on, and put that all on a global scale. Next slide. And the deliverable from this first global initiative was published early 2020, the first global evidence-based desmoid consensus guideline. Next slide. 5 years later, 2023, it was definitely time for an update. We had more data on cryoablation, which was just shown. We had specifically more data on the systemic therapies, especially on the new emerging gamma secretase inhibitors. So it was time for an update, and that was actually the workflow and the methodology we followed. We started in 2022 with a kickoff at the CTOS meeting in Vancouver. Again, did a literature search, not such a broad one as we did for the first version. We divided the work into smaller groups, writing committees, and drafted a paper, which was actually the basis for our meeting in Milan in June last year, and then worked on the publications. The next slide just highlights that a literature search was done, but this time only for the randomized trials for systemic therapies, such as for the sorafenib trial, the nirogacestat trial, which I will come to that in a couple of minutes. I just want to highlight this because this literature search was actually supported, financially supported by the DTRF. Next slide. It was just a one-day meeting in June last year, so we cannot cover everything at such a one-day meeting. So what we try to do is focus on what we called the hot topics: the positioning of local therapies versus the systemic, the medical therapies. When we go for medical therapies, is there actually a first line? What are the remaining indications for surgery and radiotherapy, or are there still any remaining indications? We focused or we dedicated more time and more space to two specific patient populations, the pediatric patients and the FAP patients, and we also invited experts and also patient representatives from these two patient populations. We looked at quality of life and benefit and updated the overall treatment recommendations. Next slide. And what I would like to do now is share with you the most, the consensus statements or the main consensus statements we actually wrote down. So the first topic is the positioning of local therapies. Jean-Emmanuel also already highlighted that. Cryoablation is the one where we actually have the best data yet. There is only one prospective trial which was presented, the CryoDesmo-1 trial. And according to this trial, the indication for cryoablation at the moment is a growing desmoid tumor after 2 or more lines of medical therapy or with functional symptoms or pain. A multidisciplinary discussion is important. I just want to highlight that cryoablation or cryotherapy is not available in every center and country and requires, Jean-Emmanuel also highlighted that as well, a very specific interventional and radiological expertise, and conducting randomized clinical trials, of course, is always encouraged, as our French colleagues currently do. Next slide. The next slide is looking at the available systemic therapies, randomized phase 3 data, which for us is the highest evidence we can gain, actually only exists for sorafenib and nirogacestat. And meanwhile, the later one, nirogacestat, is the only approved drug in this disease indication. And next slide, I would like to highlight now these two medical treatments a bit more in detail. Sorafenib was tested in a phase 3 trial published in 2018, so already 5-6 years ago. And that was actually the first phase 3 trial that was ever performed in this disease. It was tested against placebo, and there was a clear advantage in favor of sorafenib in terms of progression-free survival, and the overall response rate was 33% for sorafenib, but also 20% for placebo, which actually highlights the natural biology of this disease. Next slide. The second compound which was tested in a phase 3 trial is nirogacestat, a so-called gamma secretase inhibitor. And we tested that in a trial which was called DeFi, a phase 3 trial of nirogacestat for progressing desmoid tumors. And I had the privilege to present this trial 2 years ago at the ESMO meeting in the presidential session. And I would like to show you a bit of the details and the results of this trial now. Next slide. That was actually a phase 3 trial, a large a large global randomized double-blind placebo-controlled phase 3 trial. So we compared nirogacestat versus placebo in 142 patients across 37 sites in North America and Europe. The primary endpoint was progression-free survival, but we also captured a lot of secondary endpoints, not only the objective response rate, but also a lot of patient-relevant endpoints, which means patient-reported outcomes. Next slide. The primary endpoint or the patient characteristics actually is the next slide. I just want to highlight here that, of course, we have a young patient population. Median age was 34 years. We have a female predominance, which is not a surprise, with 2/3. We have 25% intra-abdominal and 75% extra-abdominal tumors, and we had a lot of multifocal disease, which is a bit unusual with 40%. And what you can also see here, that the majority of the patients were pre-treated with different types of therapy, either chemotherapy, tyrosine kinase inhibitors, or radiotherapy or surgery. The next slide actually shows the primary endpoint of the study, which was the progression-free survival, which was quite impressive. Nirogacestat significantly reduced the risk of disease progression by 71%. So the median progression-free survival for placebo was around 15 months, and it was not even reached for the gamma secretase inhibitor because there were no events in that group. Next slide. The objective response rate, which means that we are only counting the complete and the partial responses, which means, according to this definition, that there has to be a shrinkage of the tumor of at least 30%. So the objective response rate for nirogacestat was 41% and was only 8% in the placebo arm. And we could see complete responses only in the nirogacestat arm in 7%. The time to objective response was quite fast for nirogacestat, 5.6 months, and was almost doubled in the placebo arm. The next slide. The next slide demonstrates just one example of the patient-reported outcome measures, which were actually captured. So as I said, we looked at a lot of patient-reported outcomes. We looked at pain, we looked at symptom severity, we looked at physical role functioning, and we looked at overall quality of life. And this is just one example showing that nirogacestat significantly reduced the desmoid tumor specific symptom burden. And this was actually captured here by a score which has been specifically developed for desmoid tumors, which is called the Goddess score. But to be honest, we also saw the same results with the very traditional scores. We are also using, like, there is one from the ERTC. So there was a very consistent improvement in terms of symptoms in favor of nirogacestat. The next slide is actually highlighting the The side effects, of course, we also saw a couple of side effects. The most frequent were diarrhea, nausea, fatigue, hypophosphatemia, and rash. However, the majority of these side effects, 95%, were all grade 1 or 2, so rather of low. And when they occurred, they usually occurred very early after the start of the treatment, so usually during the first cycle of treatment. The next slide is highlighting one very specific side effect, which we called ovarian toxicity, actually defined as abnormal reproductive hormone levels. They can go with or without the presence of perimenopausal symptoms. When we looked at the female patients of reproductive potential in this study, 75% of them reported signs of ovarian toxicity. However, in all of these patients, in the 11 patients who stopped nirogacestat for any reason, this ovarian toxicity resolved in all of them in 100%. And even in the patients who continued nirogacestat, we had an ovarian toxicity resolution in 2/3, so in 64%. Next slide. So we published that very prominently in the New England Journal of Medicine last year, but what is even more important is being shown on the next slide. And this is the fact that this trial actually led to the approval of the, you can go to the next slide, Lynn. Yeah, to the approval of nirogacestat, which is now called Ogsiveo, for adult patients with progressing desmoid tumors who require systemic treatment. And this is actually the first therapy which was ever approved in this disease indication. Until now, it's only approved by the FDA, which means only in the US, and that was in November last year, so almost 1 year ago. In Europe, actually, the European Medicines Agency is currently evaluating the file, and we hope that we will have approval maybe beginning of next year. So next slide. I will come back to the consensus statements now and the recommendations we made. So as I could show you, the phase 3 data is only available for these two compounds, for sorafenib and most recently for nirogacestat. But what we are lacking actually are comparative studies. So there is no study comparing nirogacestat versus a tyrosine kinase inhibitor or nirogacestat versus chemotherapy. So we cannot actually give a definitive sequence of the existing systemic treatment option, which is actually not a problem, because if it comes to the selection of therapy, you have to look at the toxic effects of the therapy. You, of course, have to look at the tumor parameters, and of course you have to look at the specific patient situation. And the richer the armamentarium is, it actually gives you a more or it gives you multiple choices for each clinical scenario. A question which is always posed is, how long do we have to treat? And to be honest, we cannot really answer this question, because there is no high quality data for that. But the consensus of the group was to treat patients for at least 6 to 12 months prior to assessing effectiveness. Next slide. Touching now surgery, are there still, I mean, you might be aware, of course, that there has been a paradigm shift in the treatment for desmoid tumors. 15, 20 years ago, they were treated by extensive surgeries, and at some point we found out that a watchful waiting or an active surveillance strategy is actually leading to the same results than doing surgery. So there was a paradigm shift, or there has been a paradigm shift in the last 10 years from surgery now more and more actually to medical therapies. So is there still an indication for surgery? In sporadic mesenteric desmoid tumors, it is actually only the case when we have complications such as bleeding, obstruction, perforation. Then surgery plays a role, but the goal in this scenario is not to achieve a complete resection of the tumor, because this may be associated with unnecessary morbidity. And when we have a non-mesenteric desmoid tumor and we have a progression on active surveillance or medical treatment, surgery may be discussed as a kind of second or third line option, but only when the morbidity of the resection is limited. The next slide is touching the indications of radiotherapy. Actually, radiotherapy doesn't play an important role anymore. It may be a modality when the desmoid tumor is too large for cryoablation and when surgery may be associated with unacceptable morbidity. And what is also very important to keep in mind, that radiation is not indicated as an adjuvant to surgery, because this is the usual management strategy we do in sarcomas, but this is not the case in desmoid tumors. Next slide. As I said, we covered two specific patient populations. I just want to highlight here the pediatric patients. In principle, the treatment recommendations are very similar. At diagnosis, an initial observation is recommended. Tumor resection should be avoided. The type of first-line therapy is a bit different in the pediatric population. Here, a weekly intravenous methotrexate vinblastine regimen is usually the standard. Tyrosine kinase inhibitors are not very well studied in children. We only have data in young adults here. And the use of gamma secretase inhibitors, such as nirogacestat, should be delayed until the results of the ongoing trials in children are available, which might be beginning of next year. And again, regarding the duration of therapy, 6 to 12 months is frequently proposed. Next slide. Just highlighting the quality of life and benefit. Oh, we just, can you go back? Yeah. Just want to highlight here that this is a disease which, of course, requires an interdisciplinary supportive care. Desmoid tumors can have major impact on patients' lives, their social interaction, ability to work, relationship. So a collaborative and personalized management is really important. And we always should include pain specialists, physiotherapists, psychologists, and social workers if necessary. The next slide is highlighting the update of the treatment recommendations. And this is just one example, one of these algorithms in the paper, which looks at the initial diagnosis. And I just want to highlight here that active surveillance remains the frontline approach in the majority of the patients, and only in the case of a persistent tumor growth or when the tumor becomes threatening to life, to function or quality of life, then an active treatment is indicated. So last but not least, next slide, we published this update of the consensus initiative and the consensus recommendations in JAMA Oncology in March this year as a review article. And this is, by the way, the group with whom we met in Milan in June last year. Overall, with the people online, we are a group of almost 100 people now, and it's a fantastic team with whom we work together over the last 10 years. Last slide, I think, is the next one. Yes, I just want to say thank you for your attention. Happy to take any question. And I especially like to, if you click one more, Lynn, I especially like to thank Alex Gronke, with whom I'm pushing forward this initiative now for almost, for 10 years. Thank you very much.
Okay, wonderful, wonderful. Thank you so much, gentlemen. Okay, so it looks like Dr. Kurtz, it looks like you've been answering a lot of these questions. It looks like that one stands out for Dr. Casper. Is there any news about nirogacestat? Is there an update as to when the EMA is going to approve it? And this person, Hendrik, says, thank you.
Yeah, I mean, as I said, I think it was filed in, I mean, which means that the dossier was handed in February, March this year, and EMA is currently evaluating the case. We are expecting approval, I would say, early next year.
And then I had a quick question, Dr. Casper. So we know that the latest version of the consensus paper came out in June, and we're learning that you guys are working on patient guidelines right now that will eventually be able to push out to the community. The hope is that that will probably be done by the end of this year or early next year, is what we heard. Does that sound right?
Yeah, I mean, actually the whole paper is a pretty long one, and because there is a supplementary part which is pretty long, but and what we are trying to do is doing a patient version focusing on the main consensus statements, which I actually presented to you now, and that is something we would like to finalize by the end of the year, and then of course a bit depending on the national patient organization, this version could be translated into different languages then, of course.
Got it. Okay, thank you.
Do you hear me, Lynn?
Yes.
Yeah. I just wanted to say that I don't want to answer in the Q&A specific questions to personal cases, because it's really difficult to answer those questions without seeing the patients, without seeing the MRI. My advice is ask your doctor. Be sure that this doctor is aware of desmoid tumors, or seek for a doctor in a sarcoma or mesenchymal tumor board hospital. There are plenty of. And for those who are living close to Strasbourg, France, of course, you can reach me by email if you want to send me some images and come to see us in the hospital. Of course, more difficult for those patients who are overseas. But it's not that I don't want to answer questions. It's really difficult without seeing the patients and seeing the MRIs, and it's so complex. There's a question that just popped up seconds ago about the jelly in the treated zone. So do not touch the jelly. Do not try to put a needle in that and suction the jelly. It goes away spontaneously. It can take weeks or months, and it's not painful. But do not touch, otherwise it might pour by the hole you just made with the needle, and it will be very it will be a problem, because it might be infected. So don't touch ever.
Maybe Jean-Emmanuel, as I think this question also popped up, and as this is the focus of the webinar today, it is always about the availability of cryoablation. So maybe you can say a few words on that. And yeah.
Yeah, okay, this is really a good question. I know that there are more and more centers who want to have the technique, and there's a learning curve of the radiologist, as there is a learning curve for everything in life. So I think generally speaking, there are patients advocacy groups. There are DTRF, of course. There's one in France, and we know where to go. And it's interesting and preferable to ask your doctor, do you know where is the closest sarcoma referral center? And generally speaking, of course, it's not malignant, it's not a sarcoma, but the doctors who take care about desmoids are usually the same. And if they are not in close relation with the interventional radiologist, they know where to find him. And it's not experimental, and it's sometimes it's really difficult even in the hands of a trained radiologist. So and it's never an emergency. Of course, everyone wants to have access to the cryo tomorrow because it's pain somewhere to have this pain, and okay, but take the time to find the right center, discuss with the radiologist, discuss the consequences, discuss the procedure, because I did not have time to discuss everything. And more and more centers appear, but I think you should privilege the high volume centers with more experience and expertise. There are plenty of. And the question of reimbursement, of course, varies with the countries. It's reimbursed in France. I don't know about Switzerland. The question popped up. It depends whether you have an insurance, and it's really varying with different countries, and I don't have all the answers.
Okay, let's move on to a couple more questions because it looks like there are some more coming in. So in the case that a tumor is not completely ablated with a first round of cryo, can cryo be done again in the same general location?
So this is a very, very good question. In the Cryoablation 01 trial, we have treated patients with huge tumors. And we found that even in patients where the tumor could not be treated completely 100%, there was a significant decrease in pain and disability. So the benefit was there, also in patients in whom the tumor was not completely resected. And my advice is if there is a small remnant of the tumor, which is not progressing, not painful, not disabling, do not touch, because cryoablation is under general anesthesia. There are some risks, as with any general anesthesia. So if there is a small remnant of the tumor, don't touch. And sometimes the remnant of the tumor is in a place where the radiologist did not want to go. So in trying to do better, it might be worse, especially if there are organs at risk, specifically nerves, plexus, sciatic nerves, etc. So doing cryo after cryo may have some sense, but it has to be discussed with MRI clinics, seeing the patients, and be balanced with doing nothing but active surveillance again, or doing, sometimes TKIs, pazopanib or sorafenib. And sometimes you can have good results with medical treatments afterwards. So cryo is not the answer to all situations. It can be discussed in many situations, but it's better to think before than to regret after.
Okay, thank you. Is there a chance that cryoablation will anger the tumor and make it bigger?
I've never seen that. And it's definitely less aggressive than, cutting the skin and the muscles, as we see that with surgery. And I've seen really many patients treated with cryoablation for more than 10 years now, maybe 15. And 10 years. But I've never seen, an activation of the inflammatory process, or, speeding the tumor in the zone that was cryoablated. Never, ever.
Okay. How does cryoablation's effectiveness vary between early stage desmoids and later stage desmoids? And are there any specific sizes or volumes that are more suitable for cryo?
Plenty of very good questions. Well, physically, I think there is absolutely no difference, because you're icing, freezing the cells, and they will die in the same way, even if it's a new tumor, a small and a big one. This is why we wanted to go with Cryoablation 02, which an inclusion criteria is that the radiologist thinks is able to freeze 100% of the tumor with adequate margins, because we want to get rid of the lump. But the only issue with big tumors is that the interventional radiologist will need more needles, because we will have to join more ice balls together to cover the entire volume. And the bigger the tumor, depending on the location, the higher the risk to be close to vascular structures or nerves or bowel, or I don't know. So it's the volume by itself is not a complete contraindication. It might be so big that the radiologist doesn't want to treat the whole tumor at once, but maybe in two different sequences. And again, the problem is only the number of needles and the swelling, because the bigger the tumor, the more important the swelling afterwards and the initial pain. But we have treated, Afshin Ganji has treated very large tumors, and we know that it's feasible.
Got it. Okay, we're going to get in just a couple more questions. Is the Cryo-Desmo 2 study funded, or are there costs involved for patients?
It's funded. So far, we can only enroll patients from France, and I think it's feasible. I think I need to check that it's feasible for patients in the EU. So Switzerland is not in the EU. The British are out of the EU. They chose it, right? And so far, I don't think that we can treat patients from foreign countries in the trial. It might be possible, but we need to translate the informed consent, translate the explanation letter in patients who are not French speaking. So there's some kind of bureaucracy. I'm not saying that we won't do this ever. So far, we are opening the French centers. I think 3 of them are already opened. In my city, we have enrolled 5 or 6 patients so far in the cryo and in the medical treatment. I saw a patient yesterday. So we will see. If the trial is not recruiting efficiently, and I think it will, we will consider enrolling patients from Germany, maybe, which is close to France, and maybe Switzerland, maybe Italy, I don't know. But so far for patients in the US, it's not feasible. What I want to say is that it is an option in the guidelines as a first-line treatment. I had a strong discussion with Alessandro Gronchi, who said, why do you randomize? It's valid, do it for all the patients. No. I want to have solid data to be sure that it's at least equivalent to first-line medical treatment, and in my opinion, it's even better. And if we can demonstrate this through the randomized trial, this is the ultimate goal. But in some individual cases, you might want to discuss with your doctor and the radiologist whether it's feasible to be treated by cryo outside of the trial. I don't know whether I answered the questions. Oh, Lynn is frozen. Are you back?
I am.
You are
Sorry about that. Here I am. Am I still frozen?
No,
No,
you're not.
it's fine.
Okay,
Fine
great.
now.
The ice is gone.
Okay, the ice is gone. Okay, and I think we just have one more question, and then we'll wrap up. Is cryoablation indicated for a recurrent tumor after surgery that has slow growth? Can it be indicated for a recurrent tumor after surgery that has slow growth?
Well, it depends what is slow growth. If it's painful and growing on 2 consecutive MRIs, yes, it can be discussed.
Okay.
I mean, having received a prior surgery is not a contraindication to cryo, provided there is no vicinity of nerves, vascular structures, etc., etc.
Okay. Okay, I think that's it. I just have really quickly before we close up, remember each desmoid tumor case is different. These conversations are not intended as medical advice for any individual problem or as a diagnosis, treatment plan, or recommendation for a particular course of action, and should not be used as a substitute for professional medical advice and services. Dr. Kurtz and Casper, thank you so much for taking the time to speak with our community. And we'd also like to thank community members for joining us this afternoon. After being formatted, this broadcast will live in the DTRF video library. I wish everyone a wonderful afternoon, and gentlemen, I hope you have a wonderful evening.
Thank you so much. It was a
Thank you so
pleasure.
much.
Thank you so much. Have a great evening. Thanks.
Yeah, bye-bye.